turn of Professor Manish Khanna. Professor Manish Khanna is a true leader in the field of rheumatology. He has been there since the founding days of Indian Orthopedic Rheumatology Association. He continues to be advisor of IORA. He is professor and head of the department of a medical college, which is an autonomous body at Ayodhya also. And most importantly, regarding his contribution to rheumatology, he has edited and written a book on rheumatology. So 3 cheers to Dr. Manish Khanna for his continued interest in the subject of rheumatology. And
thank you so much, sir.
Over and above, he also has started a fellowship program in rheumatology. Professor Khanna, he speaks on what to be remembered.
Thank you so much, sir. Thank you so much, sir. So without wasting time, just going to start. See, I think a lot of young orthopedic surgeons, osteoporotic hip fracture is a window actually for osteoporosis, most of the time requiring a surgical intervention, because the wrist osteoporosis does not always require. Hip is very fragile, we all know, and it is actually very well explained in the beginning also. We are missing and we are seeing a lot of osteopenic hip fractures. It is in the increasing trend. It again needs a proper study, how much fractures we see in the osteopenic stage of the hip, which is a need of the hour, and hope in the due course of time in coming years we'll be able to do that. Now, a lot of the issues, why there are a lot of the issues are there with the proximal femur? Actually, it is notorious. Why it is notorious? Because entire body weight is passing to 2 small globes, which are having a less area and wearing the weight more. So it has a lot of potential. Secondly, it's a wonderful ball and socket joint. And before attempting any surgery, we should think over it. We should plan over it. It should not be taken as for granted that this is the basic bread and butter. We have to give a full movement to that particular hip. Thirdly, the most important thing, as been emphasized in the last webinar and this webinar also, the things start from the OPD, from the endo time. When the patient is coming with a hip fracture, definitely you're going to manage it very well in a 3-4 days of time. But definitely, please rule out important histories, nothing to discuss it again. Only one, that anti-epileptic drugs is a very common thing which is being taken by many patients. And we all know that this drug has a lot of changes in calcium and bony metabolism. So please, after the surgery, ask your medical colleague that what to be done now, because you're going to start anti-resorptive and all the things. Thirdly, fourth thing is most important, that type 2 diabetic patients in the elderly age group, they turn into hypothyroidism most of the time. And hypothyroidism in a traumatic patient, we are not interested in a trauma patient to get TSH done before the surgery. But I will emphasize this thing, that if it is a uncontrolled hypothyroidism, then it is going to lead to a lot of complications as a peripheral vasodilatation and different things which are not to be discussed in this topic. So the moral of the story is, hip surgery is to be executed very carefully, just not thinking over it, that is hip surgery, just start zoledronic acid and go away. Now, most of the time we are planning osteosynthesis, and that is to be done if the age is less, and even if the age is 60, 65 or 70, because the life expectancy is more. Now, very few points for the basic points for the resident, which may be something very stupid, but it's very important to emphasize is, age more than 60, the bell should ring in your mind. Whatsoever current technique we are planning to use for the osteosynthesis, I'm talking about osteosynthesis maybe in trochanter, sometime in intracapsular also, your CC screw, your dynamic fixation, intramedullary implant, even your hydroxyapatite screw to give a wonderful result. One should think that we are dealing with a living bone and making it with a compatible to the inert implant. That has to be taken care right from the patient which is entering into the OT and coming it out, and that living bone is weak and fragile. So your assistant, your everything should be very cautiously managed. The result of the surgery depends definitely on bone quality, fracture pattern, which is, we can't control on it, but definitely reduction, implant design, implant placement. Moreover, in an osteoporotic hip is to be considered. Specifically, just I place a point that even if you feel that it is very much osteoporotic, please try. Always we should give a valgoid reduction to the implant, but please try to give a better valgoid position to this osteoporosis hip so that when the patient is going to bear the weight, there should not be a problem. Now, this on the right side is definitely osteoporotic patient, which was being operated many years back. It's not being used again. But again, there was a time when actually we don't use a intramedullary implant. The right side case is very vigorously managed. A lot of wires have been done. Very, patient was having a good weight bearing was being done initially, and there was a mishappening. You can see here. There was a time when extramedullary implant was the best thing, but now we all are using, nothing to tell about it, that intramedullary. As soon as we see a patient is osteoporotic, we try to give intramedullary if it is possible. But definitely one should remember high failure rates are again with the intramedullary implants. Implant screw placement and everything is very important. So best would be to place both the type of extramedullary, intramedullary as soon as you are confused whether, because you're going to have a reduction. We don't know actually. So for the bigger center, definitely it is a thing, but still many orthopedic surgeons are at periphery level working there with a lot of the things to be required. So please make it a habit. We Indians are now moving ahead to the Western world that to place all the extramedullary and intramedullary implant at the same time. Because if it is an undisplaced fracture, then definitely you will look over for the bone stock. And before operating, please take a proper history whether it is undisplaced with a proper bone stock, because the impact was less or the impact was more. Because if the impact was more and it's undisplaced, the bone stock is good. But if the impact was less with the travel history, and you feel, because every time it's not possible to go for a CT scan and this and that. So you have to work it up accordingly on those levels which we miss most of the time. Similarly, if it's a displaced fracture and if you're making it to reduce it, so again, most of the time you have to work upon the bone stock to see whether the bone stock is sufficient to take it. As I've already mentioned, CT is not possible, but at least an X-ray of the other hip can help you out, because getting an X-ray done of a lateral view is also not possible because of the pain, but at least on the other view can help you out, especially if you're dealing with a pathological fracture. Because you never know that at that particular site, I think everybody's taking point, that particular site, whether the lesion was there or not. So we land up with the failures. Comminuted lateral wall and all those things. I'm sorry for this slide, which is very unclear. Definitely we should plan if possible for the intramedullary, but have to be enthusiastic and need not to tell to go for a definitely medical management. Implant loosening is a normal problem, and that has been there with all the implant, but for the DHS, it is a big thing. Definitely we have to work upon think over the via debris, because if you're feeling that it's an osteoporotic patient, it is going to have a via debris induced osteolysis. So either you plan a good therapy before going of weight bearing, or you can see whether the weight bearing to be minimized. So it comes with the experience, and I think everybody will appreciate to this thing. For example, I'm placing this of one of my error. A subtrochanteric fracture, which was being reduced very enthusiastically. Lateral view was not being taken, and unknowingly, it was being fixed with a little displacement. So here again, the patient when come, we found it after 1 month of time that it is having a little displacement. So we have not gone for a revision, but we made it to unite somehow. So proper osteoporotic means you have to work it up very properly. Refractures are there in osteoporotic patient, which we need to work up properly. Similarly,
we have to conclude in 1 minute.
1 minute, sir. One thing I would like to emphasize that a good close reduction, if possible, can be attempted. And I'm sorry to say, even today's Campbell is not having a good close reduction methods like Ledbetter and Whitman, which we have studied in 7th and 8th edition. So for all youngsters, please try to respect that hip without having a more vigorous reduction. Go for these techniques to go for it. And then I think this is a long lecture which I prepared, but definitely a recent thing which I just want to emphasize before concluding is 3D print implant is now going to come, because now we put a cement and then again osteoporosis and then again loosening and all those things are there. We hope that with the 3D titanium pores coating which are available, if your medical management is wonderful, then you will be able to grow the bone and growth in these holes, and you can lead to a very healthy bone gradually. So definitely these cementless acetabular femoral components, titanium trabecular lattice is the next thing which is going to come, and we're going to see, we're going to witness this and going to use it. But definitely to be using this, one should go through all these previous things and then to go for it. So now 2022 is there. By 2050, all of us who are here, we're going to see a tremendous rise in hip fracture. So we have to take it very seriously if we want to give a wonderful, good result. That is the nature of a human being, and that is the thing to be served to the humanity. Thank you so much for a very patient hearing.
Thank you, Professor Manish, for delving so very deeply into the various points worth remembering. And you have culminated rightly by saying that the future holds for further development in the field, including 3D implants.